Hi everyone, welcome to week 7 of the Psych Elective. This is our final week. Before we go over what you'll be doing this week, I just want to review your assignments from last week. So the topics you had were pediatric psychiatry and then geriatric psychiatry. So for the pediatric psychiatry materials and assignment, you were asked to kind of play a patient simulation of a young boy who has depression, and his family is coming in for some relief, some help. So the options that we had were medication-based. Several of you noted that under your ethical considerations that psychotherapy should also be considered, and that is 100% correct. We should also consider psychotherapy. Sometimes families are not looking for that depending on the severity of the depression. They want something that can kind of start working right now, or their access to care doesn't allow them to be able to come in as frequently as needed for psychotherapy. So there's a bunch of different considerations. So those of you that brought that up in your ethical considerations, that was a really great point. You also all brought up kind of, considering the patient and what the patient's needs are, the side effects the patient's experiencing in that decision making, as well as the whole family. So those were all really great responses for that. For the treatment decisions, since we were kind of limited to pharmacotherapy, you were also kind of limited in your initial choice of drug, right? So you had Wellbutrin, sertraline, and paroxetine you could have started the patient on. First-line treatment for pediatric depression is going to be SSRIs. The one SSRI that has had more consistent results in showing increased efficacy at reducing depressive symptoms over placebo has been traditionally fluoxetine. That wasn't an option for your first decision. Sertraline and paroxetine and other SSRIs have mixed findings in results and meta-analyses. So those aren't as consistently positive in clinical trials as fluoxetine has been. But those are also potential options. So you could have started with either one of those. You kind of will consider things to consider would be the side effect profiles. Regardless of which one you choose, you would start off on a lower dose and then titrate up based on the patient's symptoms. So one thing to keep in mind with pediatric dosing and treatment options for any psychiatric condition is most of our evidence to support our treatment recommendations comes from treatment in adults. So we're trying to extrapolate how we would treat an adult and our findings in adults to children. And I brought this up in that brief lecture I had recorded. The problem with this is that there are constant changes that are occurring neurodevelopmentally across childhood and adolescence, in these different brain areas or brain systems, so the serotonin system's changing, that those systems might not respond the same way to a particular treatment that we would give to an adult that would be very efficacious and have the same effect in a child. So that is a limitation right now and something to always be aware of. Starting off low is good and working your way up to try to mitigate any potential side effects, but also try to provide some relief. So if you chose one of the SSRIs, you probably noticed in 4 weeks the patient came back, wasn't really showing much response. And so the response or the outcome that we're looking for there is we want to see a reduction in their depressive symptoms. And so we could have used the same scale that the nurse practitioner had used when they started to see if there's a significant reduction in his score on that scale. And so when we talk about a good treatment response, we're thinking about a 50% or greater reduction in symptoms. And so that would be considered responding. And then remission would be where they have very little to no symptoms anymore. So first step or first goal is to get a significant reduction. We want to see a treatment response. And then we can play around with the dose a little bit. We can either maintain it to see if we can get further reduction with that same dose over extended trial of the medication, or we could slowly titrate up to see if we get increased treatment response but also while monitoring for potential adverse effects. If this patient is experiencing adverse effects, difficulties with nausea, vomiting, sleep disruptions, we might consider switching to another SSRI. Another reason our patient may not have been responding after 4 weeks was, and a lot of you pointed this out, was because of the duration of the trial with the drug. It could take, 6 weeks to 8 weeks to actually start to see some sort of response to the medication. So that's another consideration we have to make. Do we at this point say, you know what, we want to wait it out a little bit longer with this medication, or do we want to switch him to another SSRI? Okay. Either one of those things would be fine, and that's going to be a clinical decision-making point for you, as well as consideration from the family and the patient themselves, kind of what they would like to do, and kind of weighing the risks and benefits with that. Okay, so great job with that. I hope you enjoyed doing the MOCA with one of your family members or friends. It's kind of interesting to see how these different domains, depending on how somebody performs, can be used to assess cognitive function and can be used in geriatric psychiatry for assessment of dementias. So that was the other kind of area that you had focused on. Dr. Bacon had put together that worksheet for you about dementias. And so everything looked really good, what people had on there, kind of identifying first the difference between delirium and dementia. While they might show some similar kind of behavioral symptoms, their etiologies can be very different. So dementia is typically a more gradual, slower onset, and it's generally irreversible. It's chronic, progressive. It has changes in the brain that are associated with it, whereas delirium tends to be typically acute, kind of sudden onset, but can be reversed and is usually caused from some sort of external factor. So it could be something like a physical illness or infection, a drug, or some sort of exposure that once it's removed or corrected, the delirium goes away. Okay. So that was kind of the main differences there, and then asked you to kind of describe differences between different types of dementias, which everybody, it looked really good that you had filled out that table. And then there were some different guidelines you could have identified for evaluating the appropriateness of medication regimes in geriatric patients. And so there are a variety of things like the Beers criteria from the American Geriatric Society, the STOP, which is the screening tool for older persons prescription, START, screening tool to alert to right treatment. These are all used for, especially in geriatric patients, because of polypharmacy and the concerns of potential interactions and side effects in our elderly population. So, but there's even more than that a lot of you had identified. So that was fantastic. Everybody seemed to identify the different drugs that were approved for Alzheimer's disease with their side effects, dosages, counseling points, and so forth. The cholinesterase inhibitors, the reason we would titrate that, and everybody seemed to understand this, was to minimize the GI adverse effects such as nausea and vomiting, diarrhea. There were different agents that were listed for treating agitation associated with dementia, and asked you to list some different risks with each of the agents. And so some of you identified that any of those could be used. Some identified, I'd prefer antipsychotic and citalopram. And really it seemed that the main reason for your selection had to do with the side effect profiles. And that is something that what we were kind of looking for was, given the side effect profiles, even if all of them could work, which one would you think would be appropriate to treat, based on this? Then we had the last part of this before I had you enter in kind of your MOCA score with your participant was looking at some guidelines for antipsychotic use in nursing home patients, according to the Centers for Medicare and Medicaid Services. So this was a big document. And if you kind of did a search for antipsychotics, it would have taken you into like page 500 something. That would have given you kind of some of the guidance and the guidelines for it. And so it's used with caution, and they suggest use with caution because there is a potential risk to elderly patients that could have the movement effects, cognitive impairments, increased risk of fall, sedation, other types of things, increased risk of stroke. So there was some that if you try some non-pharmacological approaches, but they didn't relieve any of the symptoms, or if the person's presenting a significant danger to themselves or significant distress, you could use an antipsychotic as needed for 14 days and then reevaluate the patient. And so that was kind of the recommendation there. And so it was really about the caution of it because there was a huge rise years ago in the use of antipsychotics in nursing home patients that the government felt could have been inappropriate, and there was this push to come up with policies and programs to try to reduce the amount of antipsychotics that were prescribed to try to mitigate some of these negative outcomes. So, and then there is evidence to show that with some of these guideline changes and suggestions, there has been a significant reduction in antipsychotic use, as well as reduction in then those potential risks and side effects. Okay. All right, so great job on both of those assignments. This week, we're going to be focusing on mental health disparities in diverse populations. So I kind of divided your discussion boards into two. And so the first discussion board is going to focus more on, you're going to be covering more mental health in minority populations that face a lot of mental health disparities. So this could be racial, ethnic, religious groups due to socioeconomic status or location, so rural areas. So I've got a couple links to some brief facts from the American Psychiatric Association that I think is probably the nicest presentation and most concise way of presenting kind of mental health disparities and reasons for those disparities in these different types of groups. The discussion board for that is going to be about cultural influences on mental health. And so I'm going to ask you to kind of reflect on your own culture, your own family, your own experiences and environment, and how that might affect, or might have developed or formed your perception about mental health, seeking out mental health treatment, and so forth. So some cultures it's discouraged, or the things that people focus on might be more physical symptoms of psychiatric conditions when they go seek help, and with further probing, they will start to disclose more emotional type symptoms, and so this might be more common in Eastern Asian cultures. So they'll present the physical symptoms, not so much the emotional symptoms. Or, the ideas of what is causing the mental health condition or the issues that somebody's having. Some cultures are going to be more open and accepting of it. And so kind of I want you to reflect on that. You'll respond to two of your classmates' reflections as well. Then the second one is going to be about LGBTQ population. So there are mental health disparities that this population faces for a variety of reasons, and like the racial, ethnic, and religious and other socioeconomic demographic disparities, this group, I have some really nice fact sheets again from the American Psychiatric Association that kind of outline some of the major mental health disparities as well as reasons for those. This is fitting because this is Pride Month, in case you were not aware. Next month is actually Minority Mental Health Awareness. So I think that these are fitting topics for us to close out this course. So for that, I also have a video that I think it was really excellent in how they did it, and it's called Vanessa Goes to the Doctor. This is a transgender woman named Vanessa, and it's going to show you kind of the inclusive waiting room doctor's office versus the non-inclusive doctor's waiting room office versus the inclusive waiting room for LGBTQ populations or individuals. And so you can hopefully identify some of the significant things that you might not think of If you don't identify as one of the individuals in this population, you might not think about these things, but there are something that you should be aware of and you should consider. And I'm asking you for your discussion board after watching this and reading these items. I ask you to come up with some ideas on how you could create an inclusive practice site. So how would you make an inclusive pharmacy site that is kind of projecting that you are inclusive of all individuals, regardless of race, religion, sexual orientation, creed, gender, identity? You know, what things can you do in your own practice, in your own site? How would I know if I was, you know, a transgendered individual that this was a safe place for me to be and that I would get the respect and service that I deserve? So, I ask you to kind of comment on that and reflect on each other's comments. So if you have any questions, again, please don't hesitate to reach out to me. I really look forward to seeing your answers to these. After you guys all finish your discussion boards, I'll read them, and I will post one more video kind of in closing for the semester. And then I will also post a couple resources on helping you create an inclusive pharmacy that were created by LGBTQ pharmacy societies. So I hope you guys enjoy this last bit. I hope you enjoyed this course. I enjoyed having you, and I really look forward to reading your responses for the last discussion board. Have a good rest of the week. Bye.